Good morning. Today, the videos that you will see after this my small talk, that will basically is to bring home the fact that lot of old people come to us orthopedic surgeons which fracture around this wrist joint. Okay. Once upon a time, it used to be a universal fact that all these wrist fractures used to be put on plaster, and what used to happen is there used to be, after that, the fracture healing used to go a little bit haywire. There used to be a lot of stiffness, there used to be a lot of deformity. There was restriction in movement of the wrist joint. There is this restriction of the distal radial joint. This is called pronation, supination. There used to be difficulty in moving the fingers. So that particular wrist, which used to be involved in the fracture, ultimately there used to be a lot of problems for the patient to move that wrist, to move those fingers, and there used to be difficulty in their activities of daily living. So these two videos, which will follow my talk here, please have a look at it and see how things have changed in management of fracture of the distal end of the radius. Good morning. So this is a 77-year-old lady who presented to me with a fracture of the distal end of the radius. Distal end of the radius is a fracture around the wrist joint. Now, this is a very common fracture in an older individual. Fall on the outstretched hand. They fall like this on the outstretched hand, and they break the bone around the wrist. Now, the problem is this wrist fracture can sometimes be debilitating, in the sense that it can lead to sometimes a lot of pain while moving the wrist. It can lead to deformity, inability to move the wrist properly, inability to work properly, inability to move the hand. Like there can be deformity, there can be difficulty in movement of the wrist, there can be difficulty in flexing the wrist, flexing the hands. So there are certain problems where an old individual falls and they have this kind of fracture. So initially, once upon a time, a lot of these fractures used to be treated conservatively, that is with a plaster cast. And as a result, there used to be a lot of angulation, stiffness, and all the complications that I discussed about right now. Now, treatment regarding this has revolutionized, and we have moved on as science has moved on. So this lady presented to me with this kind of fracture. You can see. So here the bone is broken. It's broken and shifted out. It's not only shifted out, it's sunk in. It should have been somewhere there. It just gone down here. And from the side view, we can see this whole bone. This is the fracture, and this whole bone is tilted back. It is tilted back here. It is sunk down and is moved out. So I couldn't. Even she's 77, 78. I just cannot let her go and say that we'll do a plaster and we'll accept the deformity, because she also has to have a routine functions, routine work. So I decided to give her the opportunity of going through an operation, and finally we operated on her, and this is 6 weeks since our operation, and this is what was done. This is the sorry, I'm trying to take up the name. This is the plate that we put in, and this is the present status today, 6 weeks from the date of the operation. And you can see that the plate is holding the fracture well. The fracture has started healing, though it's just 6 weeks from the date of the operation, and there will be some more time before the fracture heals. So after 6 weeks, if I look at her wrist, she's hardly got any deformity. There's hardly any deformity, and from the side also there is hardly any deformity. Or now that I'm trying to move her wrist, if I see from the sideways, she's got restricted flexion definitely, but after 6 weeks it's quite acceptable, because the movement will improve gradually. The movement will improve more and more. If I go for extension, this is more free, but there is a restriction. This will definitely improve more and more, because it's just 6 weeks on the corner. So she is doing fairly well. She's doing exercises herself. There is no physiotherapy which is involved. This is the amount of flexion of the wrist, forward bending. This is the backward bending. This is the rotation she has, which is restricted a little bit, and this is the rotation she has this way. So accepting, and this is a scar. This is the operative scar. If you can make out, this is the operative scar that we have. So Maji, कैसा लग रहा है आपको? ऑपरेशन के बाद मूवमेंट में तकलीफ कुछ ज़्यादा?
कुछ नहीं, मैं प्रिकॉशन बहुत ज़्यादा रखती हूँ
हाँ,
कि भाई लगे नहीं, बाहर जाती हूँ तो गार्ड पहन के जाती हूँ। तो
मतलब ऑपरेशन के बाद लग रहा है कि आपका मूवमेंट वगैरह
नहीं,
ठीक है, वैसे good. So after 6 weeks she has no complaint, and she's definitely, after another 6 weeks we are definitely going to see an improvement of the fracture and the improvement of a function of her wrist. She wants to do it herself, she doesn't want to keep any physiotherapist. So this is just videos just to encourage people who come with fracture around the wrist, especially old age individuals, that everything cannot be managed with a plaster cast. If a plaster cast is applied, yes, there are situations where a plaster cast can be applied and the fracture can be treated, of course, but certain fractures definitely you cannot conservatively treat with a plaster cast. Please keep this in mind. Thank you.
Yeah, good morning. So this is a video preparing to show you how we manage displaced fracture of the distal end of the radius. That's the wrist fracture. Now if you see here, this is the fracture, this is the bone which is broken and it is moved aside. This is the distal radial ulnar joint, which is called the DRHA. There's a gap and this bone not only has moved aside, it is also sunk in. Okay, so ideally this bone should be elevated somewhere around here. So this is sunk in and displaced sideways. This is if you look from the front. If you look from the side, this is the joint line. Now if you see a joint, a line along this, it is tilted like this, and ideally in a normal wrist it should be tilted like this. So this lady had to undergo an operation to give her a better result. Because of the distal radial ulnar joint dislocation, so she was put on a plate on the fracture, and for the dislocation of the distal radial ulnar joint it was stabilized temporarily with a KOR, which is pulled out around about 3 to 4 weeks post-op day. This is the side view and this is the front view. And this was later, after the fracture was healing. This was X-ray was taken a couple of months back, and this shows the elevation of the radius. Distal radial ulnar joint has fallen back. The radius has been elevated. The angulation has been corrected. This dorsal angulation has been corrected. Now going back to the patient, if you see her wrist, we get complete movement. This is flexion. We get complete extension. There is no deformity. There is complete DRUJ movement. This is the supination and this is the pronation, and if you keep a wrist like this, there is hardly noticeable any deformity, and this is a small scar that she will bear. Probably that's a mark of the operation. আপনার এমনি হাত দিয়ে কাজ করতে কোনো অসুবিধা হয়? কোনো কাজ করতে অসুবিধা? আপনি সব কিছু করতে পারেন? এক্সারসাইজ, ব্যায়াম, যোগ ব্যায়াম,
এই যেরকম করে করছি, কিছু অসুবিধা
কিছু অসুবিধা? থ্যাংক ইউ।